Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Get CME for this episode by clicking on the CME link in the show notes. Today, we welcome Christopher Crow. He is a physician executive. His Kevin MD article is titled Returning the Joy of Medicine to Our Primary Care Physicians. Christopher, welcome to the show.
Hey, thanks for having me. Long time follower of you.
Oh, thank you so much for joining me. So, first off, just briefly share your story and journey to where you are today.
Yeah, so I'm a small town kid that grew up about an hour outside of Dallas. We had a little community called Hillsboro that had 3 doctors in it, and they kind of were everything to the community. So they were population health before that was a term in the 70s, like the mayor and the head of the city council and the head of the school board and the head of the Methodist and the Baptist and the Presbyterian church. So they were people to look up to. They really helped the town in a holistic way, and I think that really I didn't realize it really till my 30s that really left an impression upon me. And so I decided to go to medical school because that's when I looked around. That was the really the best thing I saw in the community to look up to. And so I went to medical school, went to be a family physician like they did. I think somewhere during my training in medical school, I started to feel like, and this was in the 90s, that it didn't make sense to me on how we cared for people, given all the technology advances and given all the consumerism that was happening in those times, and the internet was coming on board, and it just felt very archaic and 100 years old. And I started asking the question of, like, why do we do it this way?
Mhm.
And I'm 52 now, and I still ask, why do we do it this way? And that's kind of been my passion ever since. Is like, how do we make things better, leave it better than we found it? That ultimately has led to our purpose that's been here since we started Catalyst Health Group, which is helping communities thrive, because that's what those 3 doctors in Hillsborough were doing. They were helping our small community thrive in way more ways than just the exam room. So practiced for 12 years as a family physician, grew a group called Village Health Partners, which is still in existence today and one of the largest independent groups in Texas. It's got about 50 physicians. And now it's part of what we have, this Catalyst Health Network, which has close to 1,000 primary care providers across North Texas, the Panhandle, and a little bit of East Texas. And we only do value-based care contracting, which is the shared risk on all the government lives, and a little bit of that on the commercial lives, as well as your typical ACO type contracts for that. So that's a really fast summary of kind of how we got from to here, from there.
All right. And your Kevin MD article is titled Returning the Joy of Medicine to Our Primary Care Physicians. So I'm an internal medicine primary care physician myself, interested in hearing what you have to say about returning the joy of medicine. So tell us, how did your article come together?
Well, it's an ongoing thing, like I mentioned, of how do we leave it better than we found it,
Yeah.
and keeping asking why, I think structurally, the fee for service model turns us into widgets, and all our aspirations of being a doctor when we grow up
Yeah.
and taking care of people in medical school and residency, and you get out in the real world and understand you better code this in 99214 and get to the next room. While your patients need more, create that moral dilemma on a daily basis of, how am I going to spend my time and choose at the end of the day whether I see another patient, make a few phone calls, or do I miss dinner with my family? Do I miss the soccer practice? Do I miss the ballet? Like, every day you have to make that, and it just starts to wear on you, on top of regulations and technology that is probably getting stale in your office, because we don't have the type of infrastructure generally to invest in that unless we join a big system. And then that big system, whether that's a carrier or a hospital, they have a different priority than actually keeping your patients healthy. And so you just have this dilemma on a daily basis that some people name moral injury. And so again, it goes back to the financing system to
Yeah.
me. And so the joy is, I'm seeing it in our physicians who are getting to do full risk government Medicare Advantage work. They're still living with one foot in each canoe, so to speak. But at the same time, they're starting to see a vision that we've been preaching for a while, that if we could get more of our commercial lives on a subscription model, that there's something there. You've heard it from the hinterlands, from the direct primary care physicians who have
Yeah.
just said, hell with the insurance, and I'm just going to take monthly payments. You hear about how happy they are. Unfortunately, seeing 500 patients is not going to solve our American healthcare system from a supply demand standpoint. So I'm a guy from Hillsboro, Texas, that's trying to help our communities thrive as a whole. Certainly, that model works for that physician and that 500, but it creates a gap for us nationally. And so I'm trying to still push, like, how can we help these community physicians get to this payment model? Because through our DPC doctors that talk to us and chirp loudly, and then through what we're seeing early with the government work, there's just a sense of, oh, what I meant to do is coming back. It's coming back to me. And so that's the biggest one. And when you're physicians aren't scared to work hard. It's just that they want to be working on the things where they feel like they're making an impact.
Yeah.
And so, man, they will go 12-hour days all day long if it's impact after impact after impact. But if it feels like you're relegated to a widget and you're making an impact about 2 out of every 5 minutes, then that's where it's difficult. So that's what we mean by, that's the major structural thing about how do you bring the joy back to medicine. It's not, we're not going to, meditation and wellness and all these things that come around like time. Like we have to change it structurally, not iteratively.
So give us some of your suggestions. So you did mention direct primary care. I've interviewed a lot of direct primary care physicians on my podcast. They've written on KevinMD. And like you said, I think it's relatively niche. I think their impact is a little bit limited. So what ideas do you have that can scale?
Yeah, so we feel like we're doing that here at Catalyst. Is you do have to be able to move to I think a subscription model, which is going to require you to have some type of scale and be able to take risk. And the individual physician office, unfortunately, of America today that grew up on Little House on the Prairie is not going to be able to do that. The
Yeah.
world has just changed in that way. We don't pay for by the minute for our long distance calls anymore because there's now scale and national carriers that allow us to do this in a subscription way. There's something to primary care like that as well, because primary cares are relationships, not with their patients, not transactions. And so we really got to push that. The government has actually led the way. And so how to get more of our physicians into some type of an affiliation where that's aligned with that. Again, hospitals don't do that very well. The insurance companies that are doing this, whether that be like Humana at Centerwell or Optum with some of its assets, that's a little bit better aligned. If you're part of the other broader roll-ups like One Medical or Village MD, those have a little bit different goals in mind. So there's the rest of these physicians that are 30-40% of the country still that are in this independent state that I think they have to learn to play together because they want the same thing and get the synergies of coming together like we have at Catalyst to give us the breadth of concentration in a market to actually be able to co-invest in some of these things and tools and services that allow you to perform in risk. And man, you really, really can. But it is getting into that type of formation and taking on those type of risk contracts. And then there's the opportunity to ultimately start contracting directly with employers, because employers are fed up with the current system too. And so it happened, certainly right during COVID, slowed down a little bit because of the labor shortage. But now, boy, the appetite at the employer level is really, really there. However, if you're just a single practice in a community of even, 100,000 people, it's not going to be enough to have just a location for an employer. So this, again, it's this figuring out what's common and what we amongst us. We can all have our differences, but not letting the differences that have divided us have allowed the businesses like payers and hospitals and such to really take over at our expense. And so there's needs to be a coming together of physicians to actually heal thyself and for us to move forward.
So give us a success story of your vision in action. So tell us how these practices can come together, and when they do, how can they navigate their own course rather than be coerced by some larger systems and payers and insurance companies. Give us a success story of your vision.
Yeah. I'll give you a success story of our vision that has actually come to fruition. Is I have countless physicians that now tell me, I was planning on retiring in the next couple of years. I now see a path. This gives me a breath of fresh air to practice, to be able to see a panel of patients, not 35 a day, it may be a little bit less, but you're ultimately feeling the impact you're making.
Yeah.
You in a team-based care model, leveraging technology. And now I don't see retirement next year or the next year. Like, that is the ultimate, I think, outcome that I would share with you and your listeners. That's a shift in mindset. That means the burnout's down. That means the joy of medicine's back, and they're having fun in their career again. Again, to coalesce together, well, you're gonna have to have some physician leadership, right? That's probably, unfortunately, one of the rarest things in American healthcare today. Physicians have their head down, doing their craft, whether they're primary care, specialty care, their heads are down. And unfortunately, that leaves a void that has been filled in by a bunch of administrators, MBAs, private equity that are coming in and running their own business models. And so there is this trade-off that has to happen. For it doesn't have to happen with all physicians, but you got to have physician leadership in your community that can actually help pull this together, create a vision, partner. It's a team-based sport, so you have to be able to partner with the right people, and maybe there is a management company component from that for sure, which is what we are as well. But it's got to be in a way that's in partnership with the physicians, not in ownership of the physicians.
Now, physicians in general don't have that business acumen in order to do that. And that's probably why some of them choose to partner with management organizations, right? So, you know, there's so many areas of the country where that those independent physicians, their voices have been silenced. They're either bought out, but like you said, by large hospitals, by private equity. So for these independent organizations that don't have the benefit of management support, what can they do? How can they fight back against some of these entities that's already pervaded their area?
Yeah. Honestly, I think it's really, really hard. I don't want to sugarcoat that at all. I mean, I think the smaller practices are going to have a really, really hard time remaining independent in the future. They will get squeezed out. It'll get so hard, they'll just give up. I do think, though, so therefore, I do think they have to attach themselves to some type of alliance, coalition. And there's several models in America today. Obviously, Catalyst is one in this area of the country. We're not everywhere on purpose. We try to go deep in communities rather than an inch thick and a mile long. But there are many others, especially in the Medicare world, that'll help you kind of get on that train. And I think you have to have your head up and really considering your options. And I know everyone says we're busy, but if we've gotten into this mode because we've had our head down for too long, and we haven't been taking stock of what the options are. And there are options, and I could name a bunch of them, but they're out there and they're probably knocking on the door, and it's probably worth listening to them to see what they have to offer and who some of their competitors are. I just think you're going to have to connect to some of those enablers. And that may be not the final step. This may be your first step into this in learning, but the physicians, you're right. They haven't gone to business school, but man, they're going to have a little bit more thoughtfulness about strategy and a little bit better understanding about how the business of healthcare works to help themselves in the future. Otherwise, then yes, you just have to be a cog in somebody else's wheel. I think it's going to be, that's the divergence. And by the way, that's exactly what we've seen in the last 10 to 20 years is we've gone from 0% of physicians being owned by hospitals in 1995 to now well over half are in some type of private equity or hospital or payer employee market. Now there's just so many options for physicians now. That's actually the good thing. But if you want to keep doing it in the way we're doing it, yeah, you're going to have to get some business acumen and the right type of partners.
So in your particular area, how big is your physician coalition?
Yeah, so we have close to 1,000 PCPs across, mostly in North Texas, obviously Dallas-Fort Worth being one of the biggest metro areas in the country and the most expensive, which creates a lot of opportunity. We probably have about close to 20% of the market here. And then we're out in the Panhandle and then areas of East Texas where we probably have a little over half of the markets there, which really helps, right? When you have that density, not only for economies of scale, but also influence.
Yeah.
What you then have from an influence standpoint versus, being one doctor practice in a town of 100,000 people. There's only so much influence you can have.
Now contrast how you pay your physicians versus a typical fee-for-service model.
Well, we're still in fee for service too. So I would say it's an and model, not a instead of model, because we still have most of our commercial contracts with the BUCA still work that way. However, on the all the government lives, it is a per member per month subscription model that pays them a nice once a month. That by the way, boy, during COVID they loved it especially. It just comes in, and then there's opportunities every month that get paid quarterly around quality and other incentives to make sure that we're taking the best care of those patients. And then at the end, the way these full risk contracts works, if you've saved money, then there's a surplus share back again at the end of the year. So that's why we have a lot of physicians that are telling me, hey, can we cancel my Blue Cross patient, commercial contract, or can I not do that anymore? I just want to do these subscription per member per month ones, because it's like anything else. When I explain fee for service versus subscription payment models to my teenage sons, they're like, why do y'all build a system off of fee for service? Like, it's very quickly that they get it. But ironically, that's the system we've been in for 50 years. But the physicians are beginning to want more and more of that because of the predictability and the way the incentives are aligned to improved health for better dollars. Like, literally, better health equals more dollars, versus in fee for service, better health does not equal more dollars. Only more volume equals more dollars.
So contrast the day-to-day life of a primary care physician who, say, came from a standard traditional employed practice into one of your practices. Contrast the day in their lives.
I think the first week they start to really appreciate the care team that is there to help them. In a fee for service model, you try to keep your overhead as low as possible, and you have a medical assistant, and might have one other kind of FT that's helping you, but all of a sudden you get access to a care coordinator, referral coordinator, case management, which is an RN for your highest risk patients that we help show you who they are, to let you know who that you probably know, but also give you lists of people that we think could help, social work. And then probably the biggest is the pharmacist, is having the pharmacy integrated virtually. So you have this virtual team that is surrounding you to help you with your patients right off the bat. And your MA, who's heretofore has played all those roles. Your MA's been the social worker and the care coordinator and the referral manager and the case manager. Now you have this team that can really, really help you. So you either get a little more productive, i.e. seeing your more patients, or you limit that 5 o'clock dilemma of a little more often of being able to see all your patients and make it to dinner, and so there's a satisfaction that comes right off the bat for that. Then you start to see the predictability of the financials that come in after 6 to 12 months, because now you've begun to start getting some subscription based payments, and that starts to feel safer in how you and then you start to see that your quality measures that maybe aren't that great compared to some people, your peers that have been in the system for longer, you start to get a little competitive about that, and you start looking for ways to make that better. And then you get to this, year 2 standpoint, and all of a sudden you can take a lot of pride. You can prove that you're actually providing better quality care, which every physician, you've been in many rooms where you've been speaking to physicians. One of my favorite tricks when I'm speaking to physicians is to ask them to raise their hand if they think they're above average, and the whole room raises their hand. Statistically, that shouldn't be the case, unless I just draw that kind of crowd. And so, now you can actually, with confidence, be able to show versus your peers in the market that you're really providing quality care. You got a better revenue stream from an income standpoint, and you got more of a team and technology to better take care of your patients. And guess who's thanking you for that? Your patients. They come in and go, "Thank you so much for connecting me to Tony, the pharmacist. Thank you so much for connecting me to Susie, the social worker. That is so awesome that Carrie called me while I was in the hospital and had an appointment set up for me 2 days later." We all have egos, and that strokes our ego when our patients are coming back and telling us about how our team has really impacted them. And so what is that? What do we do? Is we do more of that.
Sure.
What does that end up? That ends up creating a better opportunity to coordinate care for patients. It improves their health. It lowers the costs. We win on that from a financial standpoint.
We're talking to Christopher Crow. He's a physician executive. His KevinMD article is titled Returning the Joy of Medicine to Our Primary Care Physicians. Christopher, tell us some of your take-home messages that you want to leave with the KevinMD audience.
Well, if you're a primary care physician out there, I hope you have a little hope that there is a future, that you're very much valued and needed in the ecosystem of healthcare in America today. And there are models out there that you can be a part of that can bring the joy back and allow you to take better care of your patients and be financially rewarded for that. If you're not a primary care physician, you're a patient listening to this, make sure you get attached to a primary care physician. I realize the supply and demand is not great right now. Certainly something else to be working on, but we know that over time, if you're with a primary care physician, you lower your cost, you improve your life expectancy, and you have more good days than bad. Seems like a good vitamin we should all be taking on a regular basis.
Christopher, thank you so much for sharing your perspective, time, and insight. Thanks again for coming on the show.